Well, hi, welcome back. Welcome back. This is Patience. Today, I'm going to talk about physiological integrity again, basic care and comfort. And the subtopic is elimination. Elimination. Remember, I am talking about physiological integrity. And on the NCLEX, physiological integrity come with variety of subtopics under the test plan. So on physiological integrity, we have pharmacological and parenteral therapies. We have reduction of risk potential. We have reduction of risk potential is also under physiological integrity. We have physiological integrity or physiological adaptation is also under physiological integrity. Physiological adaptation. Then we have basic care and comfort. These are the four subtopics under physiological integrity for the NCLEX test plan. So we have pharmacological and parenteral therapies. Then we have risk reduction or reduction of risk potential. We also have physiological adaptation, and we have basic care and comfort. And I have been talking about basic care and comfort. This is video number 7. And under basic care and comfort, the topics are divided into 7 of them. That is why this is the 7th video. So I spoke about mobility and immobility. I spoke about, that was video 1. Video 2, conditions limiting mobility. Video number 3, interventions to promote comfort. Video number 4, musculoskeletal trauma. Video number 5, rest and sleep disturbances. Video number 6, nutrition. And now it's video number 7, elimination. We're going to talk about elimination. Remember, all these 7 topics fall under basic care and comfort for your NCLEX test plan. So under elimination, let's go ahead. Let's talk about urinary elimination. Elimination is what comes out of your body. So urinary elimination. So when you assess a patient's urine, what are the characteristics of urine? We are looking at the normal appearance of urine that you will see. So the normal appearance of urine, the characteristics is that urine should have a yellow color. The normal color for urine should be yellow. Consistency, it should be clear and transparent. It should not be cloudy. It should not be yellow. It should not be dark brown. It should be yellow color, clear and transparent. Then specific gravity, the urine specific gravity should be 1.010. 1.010 to 1.030. That's the normal urine specific gravity. 1.010 to 1.030. Take notice. Now the urine pH, the pH of urine should be 4.5 to 8. 4.5 to 8. And for each 24 hours, the normal urine production of a normal person or a healthy person should be 1,000 cc or 1,000 ml to 2,000 ml. So the normal urine production should be 1,000 to 2,000 ml. The serum changes. Let's look at the serum changes, the BUN. Blood urea nitrogen. The normal for blood urea nitrogen is 10 to 20 milligram per deciliter. 10 to 20, normal for BUN. Creatinine is 0.7 to 1.4 milligram per deciliter. Let's look at diagnosis. If a patient has problem with urinary system, what would be your potential nursing diagnosis? So as a nurse, you will think about impaired urinary elimination. You also think about the redness for urinary elimination, like the ability of the person to be able to know that it is time for me to pee. Then the redness, then the urine retention. You also want to note your nursing diagnosis. You want to talk about urine retention. Is a person not able to urinate without problems? Then you want to talk about urinary incontinence, retention and incontinence. These are problems you want to tackle as a nurse. Now let's talk about some definitions here for urinary stuff. So some of the definitions I'm going to talk about is anuria. Anuria, this is total urinary output that is less than 100 ml in 24 hours. Anuria, A-N-U-R-I-A, total urine output that is less than 100 ml in every 24 hours. Then oliguria, total urinary output that is less than 400, total urinary output of 100 to 400 ml per day. So if you are able to make a urine of 100 to 400 ml in 24 hours, that's oliguria. You are supposed to be able to make up to 1,000 to 2,000 normal for one day. So if you are making 100 to 400, we call that, the other name for that is scanty urine. Scanty urine. Polyuria, this one you will know, that's too much of it. So you're making more than 2,000 ml of urine a day. That means you are really bringing out a lot of urine. Dysuria, pain with urination, pain or you're having difficulty urinating. Let's look at some predisposing factors that will cause somebody to have urinary problem. We have bed rest, we have tumors, we have bladder tumors and all those kinds of stuff. Then we have prostate hypertrophy, anticholinergic medications. So for patients with prostate issues, I think I've spoken about this in several different places and the urinary system. We also have decreased bladder tone. That's previous use of indwelling catheter or childbirth. So childbirth, and if you have had an indwelling catheter for a long time, can also give you a problem with the urinary system. We have cancer, neurogenic spinal injuries as well, CVAs and spinal injury. That's problems with the nervous system. We have calculi, that's kidney stones, renal stones, stress, urinary tract infection. Now let's look at what you will do for a patient who has urinary problem. You will want to hydrate them. You want to encourage them to take fluids, to take in fluid, at least 1,500 to 2,000 ml a day. Remember, I had mentioned this when we spoke about urinary system. So the normal intake, you have to increase them. You have to tell them to increase their fluid intake, adequate fluid intake, hydration, at least 1,500 to 2,000 ml per day. That's one of the things you will do. Voiding habit. You need to know your client's pattern. You have to provide them time and privacy. Don't rush them to pee. Don't rush them. Provide them time and privacy, and you have to know their pattern. Kegel exercise. This one is the exercise you do to strengthen the pelvic floor muscle. It tightens up muscles for a count of 3. So you tighten your pelvic floor muscles and you count 3. Then you relax them and count for another 3. Then you perform lying down, sitting, and standing for a total of 45 counts. That's how the Kegel exercise is done. Let's talk about bladder retraining. Bladder retraining. So this one is, we have triggering techniques. We have stroking medial aspect of the thigh. So you put your hand and you stroke the middle part of the patient's thigh. Pinching area above the groin. You want to pinch the area above the patient's groin. Then pulling pubic hair. providing digital anal stimulation, and using, which this one is used with upper motor neuron problems, patients who have upper motor neuron problems. We have the Valsalva and Crede maneuvers. These are all used with neuron problems, motor. So that's the central nervous system. Intermittent catheterization every 2 to 3 hours after attempting to void, and Valsalva or Crede maneuver fails if the volume is less than 150 cc. You give them a time interval and you increase it to 3 to 4 hours, then 4 to 6 hours, and never more than 8 hours. So you give the patient a schedule to do these techniques, to do this Valsalva or Crede technique, and then you try it, but you shouldn't do it more than 8 hours. So at least within all this time, the patient should have peed. There is no urine in more than 8 hours, you want to be concerned. Now let's talk about toilet training. Toilet training. You don't want to, toilet training. So you never begin before 18th month of life. This has to do with the little babies. So 18 months, that's 1.5 years. A child should be able to understand that it is time for me to start learning to urinate at the right spot. It's time for, it's a natural process. The child begins to understand that it is time. Like, I just don't have to pee anytime. They start getting the sense. So for you to be able to train them to be able to pee at the right spot, the right place, then the process is the toilet training. It starts from age 18 months, even though you can have a child learn that earlier, but normally no less than 18 months. So if your child is up to 18 months, don't rush them. So we have 2 to 3 years, bladder reflux control should be achieved. Bladder reflux control. Then we have 4 years. No, we have 3 years. 3 years, regular voiding habits should be established. At 3 years, regular urinating habits should be established. 4 years, independent bathroom activities. The child should be able to go to the bathroom independently, poop and pee, and then independently without assistance. Then 5 years, night time control is expected. So at least at 5 years, a child should be able to control urinating in bed. Now let's look at some of the things you will do. Let's look at enuresis, that's bed wetting in a child over 3 years old. So for a child who is over 3 years and is still urinating in bed, you usually have small bladder capacity. That's the problem. Their bladder is still small. So more common in males. So this is a more common in male problem after 3 years. Then it tends to be, we also have those who are deep sleepers, children who sleep deep. Then when you're evaluating a patient who has bladder problems, you want to question, have they been able to establish a good voiding pattern? And for children, you want to question their toilet training capacity. Have you achieved this? So that is it about the urinary, urinary elimination. I'm going to move to bowel elimination. Bowel and elimination. When you are assessing a patient's bowels, what is your assessment? You want to assess the abdomen. The patient abdomen should be non-tender. It should be asymmetric. It should be high-pitched gurgle, which indicate normal peristalsis. That is when you put the stethoscope and you listen with your ears, you will hear a high-pitched gurgles, which will show that there is peristalsis in good intestinal movements. Stool, light to dark brown in color. So a normal person's stool should be light to dark brown in color, should not be black, should not be white. Those are questionable stuff. We have negative Goyak for occult blood. So when you do the Goyak culture, it should come up negative. And if it is positive, that means there's blood in urine. We have the negative for fat, mucus, pus, or pathogens. This comes in when you have a problem in your intestines. Then we have the diagnosis. Let's talk about, so the potential nursing diagnosis that you give to a patient that has urinary problem, bowel problems, bowel or elimination issues. You want to be mindful of bowel incontinence, that's inability to contain or to control the muscles that control the bowel movement. Constipation, we also have perceived constipation and risk for constipation, and then diarrhea. These are issues of concern to you when you are taking care of a patient with elimination problems. Now, what will you do for this patient? What is your plan? What's your implementation? You want to help promote a normal elimination. You want to help the patient to be able to move their bowel normally. So you teach the client to respond to the urge to defecate. Then you want to provide facilities. You want to provide like a toilet, I would say restroom, privacy, and allow sufficient time for them to use. That's why you see that every patient that is assigned to a room, mostly they will have a bathroom in their room. Then fluids, you encourage them to take adequate fluid, at least 8 or more glasses of fluid a day, hot liquid and fruit juices, unless they're actually on fluid restriction for some reason or the other. Besides that, you want to encourage them to take more than 8 glasses a day, but the minimum should be at least 8. Then food, you want to encourage them to eat fiber-containing foods. You want to encourage them to eat fruits and vegetables and grains. This will help prevent constipation, and it will facilitate elimination, bowel elimination. Then activities, you want to encourage them to do more exercise and ambulate to maintain good muscle tone. Emotional state, you teach them that stress will also affect the autonomic nervous system, and they need the autonomic nervous system also control peristalsis. That's the intestinal movement that also will lead to bowel problems. We have positioning for ambulating the client, for ambulatory client, for those who are walkie-talkies. You want to teach them optimal posture with their feet flat on the floor. So you tell them the optimal position. Their feet should be flat on the floor. Their hips and knees should be flexed when they are trying to move their bowel. Then for bed rest clients, you place them in Fowler's position on a bedpan. For those who are on bed rest, they have to be on a Fowler's position and on a bedpan. So when you are evaluating a patient who has bowel problems, elimination problem, you want to ask yourself, or you want to make sure that you have been able to maintain a normal eliminating pattern. You have been able to encourage the patient, teach the patient the kind of food to choose, high fiber, vegetables and fruits. You want to encourage them to increase their exercise and their ambulatory level, encourage them to drink a lot of fluids. And then you want to also ask, have you been able to promote a normal bowel elimination method for the person? Now let's look at congenital malformations of the urinary tract system. Congenital malformations of the urinary tract, not UTI. So for a patient who has congenital malformations, we have a couple. I have like 3 of congenital problems to look out for. One is epispadias. And epispadias, there's a urethral opening on dorsal surface of the penis. The urinary opening is on top of the penis. It's not right like the normal one you will see in the middle. It's rather on top of the penis. So for the nursing intervention will be a surgical correction. Nurses don't do surgery, remember that. You only help in the surgical preparation pre and post-op. So there is no incision, foreskin used in surgical repair. So they use the foreskin of the patient to make a surgical repair for the patient. So they re-correct the direction of the hole. Hypospadias, this one, the one I just finished talking about is epispadias. Now this second one is hypospadias. So remember I said epi, right? So this one is hypospadias. So the male urethra opening on the ventral side of the penis, or female urethra opening in the vagina. So we actually have some of these abnormalities. You will see them when you come to the floor as the working nurse, you will see them live. They are not made up stuff. We have patients that have them. I have personally had a couple. So that one too, the nursing intervention will be a surgical intervention to correct the hole. So that is hypospadia. Let's talk about bladder exstrophy. Bladder exstrophy. This one is posterior and lateral surface of the bladder are exposed. Posterior and lateral surface of the urinary bladder are exposed. Nursing intervention will be immediate reconstructive surgery to close bladder and abdominal wall. These are abnormalities, congenital. People are born, babies are born with these abnormalities. Let's look at evaluation. What will you look out for a patient who has these bladder problems? So you want to have their parents to adjust to the altered body image of their infant. And you also want to be sure that corrective surgery was successful. So you know that when you have a child and then you can see the urinary bladder out on the abdomen, it's a big problem to cope with. So you want to encourage the mothers to be able to cope with that situation. So let's talk about renal and urethral calculi, urolithiasis. Renal and urethral calculi, urolithiasis. When you have a patient who has urolithiasis, these are the presenting signs you will see. You will see pain. Renal colicky. They will describe the pain around the pelvic area, and then they will describe a flank pain that is radiating. So you will see that the patient is generally uncomfortable. So you will see that it also depends on the location. You know, we have two kidneys. So it also depends on the location. When you see calculi, calculi definitely means a stone. So calculi means there's a stone in the renal system. So we have, it depends on the location. There will be flank pain with renal calculi that is radiating the flank pain with urethra or bladder stones. So if there's a problem in the bladder or the urethra, there will be a radiating pain, and then the pain will often be so severe. So you have the patient holding onto the side and is kind of coiling themselves, describing the pain as unbearable. They'll be restless, diaphoresis, nausea, vomiting, chills, and fever. There'll be blood in the urine and white blood cells, and there'll be bacteria too in the urine. So for a patient who has urolithiasis, these are the things you expect to see. You expect to see flank pain. It could be right flank, left flank, depends on which area of the renal system is affected. And then there will be diaphoresis. Patient will be having colicky pain that will be radiating, and fever, urea, white hematuria, no urea, hematuria and white blood cell with bacteria in the urine. Then when you are diagnosing this patient, you will see that there's kidney stones. So we often have a procedure. We have nephrolithiasis, which is a kidney stone, and urethrolethiasis, stones in the urethra. So take notice of these two differences. What causes nephrolithiasis which is the kidney stone, and ureterolithiasis, stones in the urethra. If there is obstruction and urinary spaces, obstruction. So let's say you have the urine that is not coming out and you keep getting stuck there. We have hypercalcemia, dehydration, immobility, gout, increased intake of oxalate, that's spinach, Swiss chard, wheat, and peanuts. Increased intake of this foodstuff can cause kidney stones or stones in the urethra. When you are diagnosing a patient, what diagnostic test do you expect to have it done? So the patient will have an intravenous pyelography done, intravenous pyelogram, and then renal ultrasound, CT scan, cytoscope, magnetic resonance imagery, X-ray of the kidneys, urethra, and the bladder. Now, what will you do for the patient? You want to monitor one for temperature, and then you want to monitor that there is no temperature or the patient is not febrile. You want to avoid overhydrating or underhydrating to decrease pain when passing urine. So with this one, you don't want to overhydrate them. So you encourage them to be within the normal limit of fluid intake. Then you strain the urine and check for urine pH. You want to strain the urine to see if the stone came out. Then you just monitor them for any fever. We have analgesics that you can also give. Then we have the diet for prevention of the stone. Remember, I had mentioned some diet that you can, when you're eating them, you can have a kidney stone. We also have diets that will help prevent you from getting. So most stones will contain calcium. When they do the stone studies, when they urinate and then they strain the urine and get the stones, they send it for studies. So in most of the studies, they will find out that the stone will contain calcium, phosphorus, and oxalate. That's why the first time I mentioned that the foods that contain more of oxalate, they can cause the stone. So they'll be low in calcium if stones are due to excessive dietary calcium intake. So you want to avoid milk, cheese, and dairy products at that time when you have that stone. Low in sodium, so you want to also increase calcium in your urine when you have the problem relating to sodium. Then low in oxalate to prevent increased calcium absorption. So you want to avoid spinach, cola, tea, and chocolate. Then you avoid vitamin D and rich foods that will increase calcium absorption. Then decrease purine sources, decrease your intake of organ meat if you have renal calculi. You also want to advise the patient to acidify their urine and increase the consumption of eggs, fish, and cranberries. These ones will cause the urine to become more acidic, increasing their consumption of eggs, fish, and cranberries. Then they should also they also try to make urine alkaline. They shouldn't try to make their urine more acidic. They should make it more alkaline. They should restrict acidic fruits, and then milk and potatoes. They should eliminate. Okay, so now let's talk about some drug therapy medications to give. So you want to give the patient broad spectrum antibiotics. For a patient who has this kidney stone and a urethra stone, you want to give them antibiotic, broad spectrum. Thiazide diuretics, that's orthophosphate sodium, cellulose phosphate will decrease calcium reabsorption. So you want to also offer that. Allopurinol, that's xyloprine and vitamin B6 pyridoxine, decreases oxalic acid levels. So you can give them allopurinol, which is a medication, and vitamin B6. We also have allopurinol it will help decrease uric acid levels in the body. So now I'm just going to quickly brush through some common surgeries that they will do for a urinary tract problem. We have stenting. They place a stent in the urethra during uteroscopy. They use a microscope or a stethoscope to view inside, and then they place a stent in the urethra. During this, what is your nursing intervention? So as a nurse, you have to keep an indwelling catheter and you have to place it. So that's a nursing intervention when they have to place a stent in the urethra of the patient. Then we have retrograde uteroscopy. Retrograde uteroscopy. Ureteroscope, a ureteroscope, they use something to view through the urinary tract, is used. And this method is to take out stone. Retrograde uteroscopy is to remove urinary stones or the stones in the ureter. So your nursing action is to also place an indwelling catheter. Remember, this is a surgical procedure. So as a nurse, you make sure the patient has an indwelling catheter. We have the percutaneous ureterolithotomy, percutaneous ureterolithotomy or nephrolithotomy. This one, they use a lithotripta that is inserted through the skin. They insert something through the skin. That's the lithotripta. And they have the urostomy tube. You, the nurse. So your nursing, so as the nurse, your nursing intervention is to have you leave the ureterostomy tube in place. You have to leave it in place. Let's talk about nephrolithotomy. Incision into kidneys to remove stones. Nephrolithotomy. They make an incision through the kidneys to remove kidney stones. So we have urethral catheter incision drain. And then with this one, you don't irrigate the nephrostomy tube, or you don't irrigate the indwelling catheter. That's your nursing intervention to take note of. Let's talk about pyelolithotomy. This is flank incision into kidneys to remove stones from the renal pelvis. So they do a flank area incision to the kidneys to be able to remove renal pelvis stones. So during the incision, as the nurse, yours is to do dressing and then place a urethral catheter. Then we have uterolithotomy. Uterolithotomy. So uterolithotomy is incision into the ureter to remove stones. So most of these urinary tract surgeries are to remove stones. Most of them, all of them so far, is just to take out stones, apart from placing the stent. So your problem or your nursing concern in uterolithotomy is not to irrigate as well, and you want to also check incision drainage to see if there's blood in it, and you want to maintain a catheter. Then nephrotomy, removal of kidneys due to tumor infection or anomalies. Nephrotomy, removal of the kidneys. So this is where you use the Penrose drain. As the nurse, is the nursing function, you use the Penrose drain, indwelling catheter. You make sure there's surgical dressing, and then you check the urine output closely. The last resort will be the surgical intervention. So that's your intervention for nephrectomy. Let's look at nephrostomy. We had the nephrectomy, that's removal. Let's look at now nephrostomy. Nephroostomy. This is flank incision and insertion of nephrostomy into the renal pelvic. So we have the Penrose drain as a nursing intervention that you have to do as the nurse. So let's look at mechanical interventions for cystoscopy with catheter insertion. That's also another intervention you can do for a patient. We have the extracorporeal shock wave lithotomy, extracorporeal shock wave lithotripsy procedure. So this one is done to strain the urine following the procedure. Then the voided parts of stones are sent to the lab for analysis. Then we have you as the nurse, that's implementation. You have to encourage the patient to increase fluid intake, and you facilitate the passage of a broken stone. So when they take too much, when they take a lot of fluid, it will help the broken stone to come out. Then you strain the urine. Then you teach them to report any fever they may have and decrease urinary output. And then if it is normal after the procedure, after the extracorporeal shock wave lithotripsy, hematuria, blood in urine is expected, but it should clear within 24 hours. So after the procedure today, the patient has blood. I expect that is normal to some extent, but after tomorrow, let's say the procedure was done 10 a.m. today and tomorrow 10 a.m. I don't expect to see blood after 10 a.m. tomorrow. It's already 24 hours. So let's look at evaluation. What will you evaluate a client with bladder surgical problems? You want to evaluate the patient if the patient knows of dietary restrictions. Dietary restrictions, remember, we are talking about renal and urethral calculi problems, kidney stone issues. So dietary will help. Has the client comfort been maintained? Because I had mentioned that the stones, there will be pain, colic renal pain. Now let's talk about cystitis. This is inflammation of the urinary tract. So the patient will have urinary urgency and frequency. These are the main signs and symptoms. There'll be burning on urination, cloudy urine, strong odor to the urine. Then the diagnosis will be inflammation of the urinary bladder. That's what cystitis actually means, inflammation of the urinary bladder. Then the predisposing factors will be mostly female who are more prone than men. And then when you continue getting catheterization or any instrument in place, when they do these surgical procedures, that's invasive. It can make you have your bladder inflamed. This is an infection, urinary tract or urinary bladder infection or inflammation. So what will you do for this patient? So for this patient that has inflammation to the urinary bladder, and I also mentioned that females are more predisposed to this than men because of the distance of their urinary tract system with their urinary exit, the ureter with the bladder. So if the invasive procedure passed through the vagina to the bladder, then you expect that they can easily get infection. The distance is too short. Men have a longer one. So we have the implementation. What you will do for the patient is to obtain a clean catch sample and midstream urine specimen for urinalysis. So urine culture, colon count, and possibly brain strain. Then force fluids, 3,000 ml per day. You can give the patient IV bag or something. Cranberry juice or other urinary acidifiers, you encourage them to take that. Culture and sensitivity is also done. We have medications such as antibiotics, Septra, urinary tract analgesics such as peridium is given. You want to teach females to avoid following intercourse. You want to teach them to avoid before and after intercourse. Then you want to clean properly after you defecate, wipe front to back, not back to front. So you void every 2 to 3 hours. Your evaluation is to encourage or to have the client's symptoms subside so they don't have all this discomfort. And your other evaluation is whether the client knows about how to prevent the reoccurrence of cystitis. Let's talk about pyelonephritis. I know we spoke about some of these things in urinary system, but I'm just going over them. So pyelonephritis, when you assess a patient who has pyelonephritis, you see that the patient will have chills, fever, they'll have malaise, flank pain, urinary frequency, dysuria, and then the tenderness for CVA is possible. We also have the diagnosis. What is pyelonephritis? This is inflammation of the kidneys that is caused by bacterial inflammation. Inflammation of kidneys due to bacterial infection. Predisposing factors or risk factors: people who have had urinary tract infections, people who are pregnant, people with tumors, people with urinary obstruction, and that are usually caused by E. coli. So when you are doing a diagnostic testing for these people, we have the urinalysis, we do the RBCs, red blood cells, bacterial leukocytes, and CAS. So you want to check to see if all these things are elevated. So what will you do for this patient? You encourage bed rest during acute phase. Then you give antibiotic therapy, antiseptics, and analgesics for pain. You want to encourage increased fluid intake to at least 3,000 ml a day. This is to help elimination. Then you want to evaluate the patient. What will you look out for? You want to ask, has the client medication regimen been client been compliant to their medication treatment? Remember the medications you gave to help. So you want the client, that's mostly antibiotics. You want to help client to be able to comply with the medication, and has the client symptoms subsided. Now let's talk about glomerulonephritis. Glomerulonephritis. I also spoke about this in urinary system. Now, when you assess a patient who has glomerulonephritis, you will see fever, you will see chills. You will see blood in urine, you see red blood cells, you see protein in urine, cast dark colored urine. Then you will see weakness. The patient will be weak and pale. They will have dyspnea, they will have weight gain, lung pain, or fluid overload. Then there will be anorexia, nausea, and vomiting. That's uremia. Is due to uremia. That's why the patient will have anorexia, nausea, and vomiting. Then we have moderate to severe hypertension. That's what you can see when you assess a patient who has glomerulonephritis. Remember when I described the glomerulus for you, and I described the fiber-like net tissue in the glomerulus inside the Bowman's capsule. So there will also be headache, decreased level of consciousness, confusion, abdominal or flank pain that the patient will present without complaint, oliguria with fixed specific gravity indicating pending renal failure. We have antistreptolysin or titers that will be done, and this one will show that there's decreased serum complement levels, needing renal biopsy. So glomerulonephritis is damage to the glomerulus that is caused by an immunologic reaction that results in proliferation and inflammatory changes within the glomerular structure. Okay, so it's an immunological reaction that causes a damage to the glomerulus. You want to take notice of that. Acute glomerulonephritis. For acute glomerulonephritis, is usually caused by group A beta hemolytic streptococcal infection elsewhere in the body. That's upper respiratory tract infection. So if a patient tells you, I had common cold last month, I had common cold 3 weeks ago, and the patient presents to you with urinary problem, the first disease you want to suspect is acute glomerulonephritis, or you want to suspect is glomerulonephritis. So for patient who had upper respiratory tract infection and skin infection, since it's immunological reaction that causes an inflammatory process in the glomerulus, it has a link to that. So for patients who also had chlamydia, pneumococcal mycoplasma, or Klebsiella pneumonia, autoimmune diseases, we have the beta streptococcal infection that is elsewhere in the body, can present to you with those signs and symptoms. So take notice of that. Now, this usually will occur in 10 days after a skin or throat infection. So for a patient who has throat infection, it take within 10 days, then they present with a different problem. The throat infection is no more. Now I have urinary system. So you want to expect the glomerular. Let's talk about implementation, what you will do for the patient. You will administer medications that will help eliminate the infection. That will also alter immune balances to elevate inflammation. Medications that will treat volume, you want to also treat volume overload and high blood pressure. So these are all medications that you give to administer. So we have anti-inflammatory, antibiotics that you will give. You give corticosteroids, you give antihypertensive, immunosuppressive, and diuretics. Remember, the bacteria that cause the glomerular nephritis is beta hemolytic group A, beta hemolytic streptococcal infection, group A, beta hemolytic streptococcal infection. And after a patient has skin problem or UTI, within 10 days, they present with that complaint. So we have the plan, what you will do for this patient. I just spoke about administering medications to treat the autoimmune system disorder going on. That's the immunosuppressants that you will give. Then we also spoke about elevated blood pressure and fluid overload. You give antihypertensive. We spoke about corticosteroids and for immunity, and then we spoke about antibiotics. You want to restrict the client from taking sodium and restrict water if there is oliguria. If there is oliguria, you restrict them from taking water. Daily weight, you want to monitor input and output and serum potassium levels. We have bed rest. You want to also give the patient a bed resting schedule. High calorie, low protein diet. Dialysis, if there is uremia, or plasma electrophoresis, if renal failure develops. Antibody removal. So your evaluation will be to help prevent any complication from glomerulonephritis. And you also want to make sure the client is able to understand their fluid and dietary restrictions. Prostatic or prostatic hypertrophy, benign prostate hyperplasia. That's prostatic hypertrophy, benign prostate hyperplasia, benign prostate hyperplasia. This is inflammation or enlargement of the prostate gland that causes urinary flow obstruction, incontinence, and possible infection. Benign prostate hyperplasia. Enlargement of the prostate gland causes urinary flow restriction or obstruction. It causes urinary obstruction and then possible urinary infection. So it is benign hypertrophy, increases in size with age, usually over 50 years in men. And then the BUN and the creatinine, you want to check their levels. So when you assess a patient who has benign prostate hyperplasia, you want to assess them for urinary hesitancy. Their problem is urinary hesitancy, dribbling, weak urinary system, dribbling, the urine is just dropping out. We have frequency, urgency, dysuria, and nocturia. These are the signs you will see. Hematuria before or after voiding, and then urine retention that you will also see in these patients. Then we have prostate-specific antigen. Prostate-specific antigen. This is part of the diagnostic testing that you will do. So the prostate-specific antigen, the normal should be less than or equal to 4 milligrams per deciliter. And this may be increased in prostatitis, prostatic hypertrophy, and prostate cancer. They will have elevated levels of less than or equal to 4. So in case of problems, they will go higher. So we have transabdominal or transrectal ultrasound. It's also a diagnostic testing for benign prostate hyperplasia. Then we have prostate biopsy. What will you do as a nurse? Conservative treatment. We have urinary antiseptics and follow-up visit. Then we'll have you to administer alpha reductive inhibitors, 5-alpha reductive inhibitors, and then alpha blocking agents. These are medications you will give. Then we have the suprapubic cytostomy. This is opening into the bladder drainage via catheter through abdominal wall, temporarily measured to divert the urine. So you want to cover the site with a sterile dressing and you connect to a sterile closed drainage system. So you also want to test the ability to void by clamping the catheter for 4 hours. When you clamp it for 4 hours and have the client void, then unclamp the catheter and measure the residual urine. So if the residual is less than 100 ml on 2 occasions, morning and evening, that you will do it. So you do this morning and evening. And if the urine is more than 100 hours, you have to remove the catheter following that result. So you also want to remove the catheter and then place a sterile dressing over the site. So you don't remove the catheter and just leave it like that. You place a sterile dressing. Let's talk about prostatectomy. Prostatectomy. This is transurethral. Transurethral. We have the suprapubic. This is through bladder and retropubic prostatectomy. So the types, we have transurethral prostatectomy, suprapubic prostatectomy through the bladder, and then through the abdominal wall. That is retropubic resection. So when you are assessing a patient for shock, you want to assess them for shock and hemorrhage. You want to check the dressing and the drainage. Urine may be reddish pink initially before continuous bladder irrigation is needed. Then you want to monitor the vital signs and monitor intake and output as well after catheter is removed. And you want to expect urinary dribbling and urinary leakage around the wound site. So we have for you to avoid long periods of sitting and strenuous activities until the danger of bleeding is over. So you also want to complement and add alternative therapies such as saw palmetto and lycopene. You want to avoid consumption of large amounts of fluids such as caffeine, and then you avoid anticholinergics, antihistamine decongestants, medications. And then when you evaluate this patient, you want to make sure you have been able to restore their urinary pattern. You also want to make sure you know or the patient understand the post-operative care instructions. So these are your nursing interventions, your assessment, and what you will do for this patient, your implementations. Okay, let's talk about urinary diversions. Urinary diversions. When you assess a patient who has a urinary diversion, what is a normal thing or what's your assessment findings? Though these are patients that have bladder tumors that require cytectomy, they have birth defects, they have strictures and trauma to the ureters and the urethra. Those with neurogenic bladder disorders and interstitial cystitis, they will require urinary diversions method to be able to urinate. Now let's look at the various types of urinary diversions that we have and what the nurse is supposed to do. That's your nursing intervention. So we have nephrostomy. Nephrostomy. This is the flank incision that I spoke about, that they insert, like flank incision and insertion of a nephrostomy tube into the renal pelvis. So they insert a tube into the renal pelvis so to allow drainage of urine. They are diverting it from passing through the normal opening to that through the through the flank area. So with this one, the patient will have a penroll drain and you will need to do a surgical dressing. So it is a nurse's role to monitor the drainage. For the first 24 hours, it's expected to have blood in it, but after 24 hours, you don't expect blood. So when you see blood after 24 hours, you raise an alarm. We have uterosigmoidoscopy. We have the ureters detached from the bladder and anastomosed to the sigmoid column. So they detach the uterus from the bladder and then they join it to the sigmoid column. So we have urine and stool that are evacuated through the anus. Urine and stool is all evacuated through the anus of the patient. So you, the nurse, you want to encourage them to void through the rectum every 2 to 4 hours. There is no enemas or catheters. You don't have to do this procedure. You cannot give a patient enema who is having the stool through the anus or through the rectum. So you want to monitor complications, fluid and electrolyte imbalance, and pyelonephritis and obstruction. Imagine the urinary system has been diverted to go and join the bowel. The bowel, that's your colon. So you want to be careful of infection. Cutaneous uterostomy. This is a single or double barrel stomach that is formed from the ureter and is excised. They make an incision from the urinary bladder and they bring out through the skin into the abdominal wall. So the incision goes through the urinary bladder and then it comes out through the abdominal wall. So as the nurse, you know that this is a stoma procedure that will create a hole. So the stoma usually is constructed on the right side of the abdominal wall, below the waist of the person. And extensive nursing intervention is required for alteration in body image. You'll be worried. Ileal conduit, the portion of the terminal ileum. Terminal ileum is used as a conduit. Ureters are replanted into the ileal segment and distal end is brought out through the skin and forms a stomach. So we have most common urinary diversion. That's what you, the nurse, will check for. Obstruction that occurs at the anastomosed area. So we have the post-operative time. You want to monitor for mucus that if there's like traces of mucus in the urine is normal. Post-operative for iliac conduits. Remember the iliac has to do with the intestine. So the iliac, it has some stripes in it that is lining it that look like mucus. So if you see that in the urine, it's expected. We have the Koch-Poch continent iliac conduit. Koch-Poch continent iliac conduit. This is the ureters that are implanted to an isolated segment of the ileum. That's the portion of the ileum with a one-way valve. So urine is drained by a catheter with this procedure. So you, the nurse, you want to collect the urine in the pouch until the drain, it can be done through the catheter. So for now, you collect it until in a pouch until it can be drained by a catheter. Then the valve that you want to place a valve to prevent leakage of the urine. So drainage of the urine by catheter under control of the client. The pouch must be drained at regular intervals. They have to drain the pouch at regular intervals. So these are some of the procedures you will do. So your main evaluation concern will be whether the client knows about how to care for the site after the urinary diversion procedure. And you also want to be with the client emotionally because of body image changes. So you also want to teach them, you want to encourage them, you want to be supportive. So acute kidney injury or acute renal failure, chronic renal failure as well. So I'm talking about all of them as once. Remember, I have spoken about all these as disease conditions in the renal system. So if you didn't get that portion well, please go and listen to that video. But I do have a little bit information on this because I am talking about elimination, and elimination is usually through the renal and the bowel system for now. So we have acute kidney injury, acute renal failure, and chronic renal failure. What will you find in a patient with any of these three problems? You'll find oliguric phase of acute renal failure. Remember the phases of renal failure, acute. So we have the urinary output that will be less than 400 ml per day. We will have nausea, the patient will have irritability, drowsiness, confusion, coma. The patient will be restless, twitching, seizures. There will be increased serum potassium, and then BUN and creatinine. They will all be elevated. We'll have increased calcium, increased sodium, and pH of the urine will decrease. So remember, in acute kidney failure, renal failure, and chronic, it's only pH that decrease. Calcium, sodium, potassium, BUN, they all go up higher. The patient will become anemic, pulmonary edema, hypertension, albuminuria. There will be albumin in the urine. All this will be done through the blood, the urine culture that will be done. Then we have the chronic urinary failure. But before I talk about the chronic one, so for acute renal failure, let's talk about the diuretic phase, the diuretic or the recovery phase of acute renal failure. The urine output will be 4 to 5 liters per day. That's a lot of urine. Diuretic, that means it's a lot of urine the patient is putting out. Remember the normal urine, the normal amount of urine output in one day, I told you. If you don't remember, go back and listen to it. I told you the daily urinary output of urine that you should expect. If it's more, that is too much. That's polyuria. You don't want that. You want to have it within the normal urinary output. So in the acute phases, there will be too much urine output. So increased serum BUN to be elevated as well. Sodium and potassium will be lost in the urine. There will be increased mental and physical activities. Let's look at chronic. In chronic renal failure, there will be anemia, acidosis, azotemia, fluid retention, urinary output alteration. What are the diagnoses that you will do? You want to find out the cause of the acute renal failure. So you have the pre-renal period. So the pre-renal period, circulatory volume depletion. You see that the volume, circulatory blood volume would decrease, vascular obstruction, vascular resistance. Then in the renal failure, we have already talked about that, and we'll talk about more in there's a table I want to discuss with you. So we have acute tubular necrosis will be the cause of it. Then there will be nephrotoxic drugs and transfusion reactions that can cause the renal failure. So we have trauma as well. We have glomerulonephritis, severe muscle exertion, genetic conditions, that's polycystic kidney diseases. Then the post-renal failure, there will be obstruction, benign prostate, hyperplasia, tumors, renal or urinary calculi. Causes of renal failure will be hypertension, diabetes, lupus erythematosus, sickle cell disease, chronic glomerulonephritis, repeated pyelonephritis, and then polycystic kidney diseases and nephrotoxins. Now let's talk about this table that I want to discuss with you is acute injury / acute kidney injury and acute renal failure. Acute kidney injury and acute renal failure. Let's talk about low output stage and high output stage. What's the difference between acute kidney injury and acute renal failure? So in the low output stage, there'll be limited fluids. You want to limit fluids in the low output stage, and the high output stage, fluids will be given as needed to replace the fluid output. Then we have the diet adjustment in the low output stage. You have to adjust the client's diet. And in the high output stage, adjustment is needed as well. Then in the low output stage, you want to give specific medications as needed. Kayexalate for potassium, for high potassium. Remember, there's potassium depletion in acute. So because there's potassium depletion at the last phase of the acute renal injury, you want to give Kayexalate for high potassium. No, there'll not be protein, there'll be increased potassium in the acute phase. So you want to bring it down by giving Kayexalate. So replacement of potassium is needed in the output stage because the patient is losing potassium. The low output stage treatment needed is hemodialysis or peritoneal dialysis. And in the high output, they still need dialysis, both renal and peritoneal dialysis. So I'm not going to go into detail with dialysis. I have a whole video on renal system, all diseases of the renal system. Go look out for that video on YouTube. I did explain dialysis for you, and you will understand it there. Dialysis is just a method used to replace kidney function. So another implementation you want to do as the nurse, you want to monitor the patient potassium levels, and Kayexalate is orally or retained is through enema. You can give Kayexalate either orally or retention enema for elevated levels of potassium to bring the potassium down. Daily weight, you want to check the intake and output as well. And then diet. In the oliguric phase of acute renal failure, you want to limit fluids, you want to restrict the intake of protein, potassium, and sodium. And after the diuretic phase, you want to encourage high carbohydrate diet and restriction of protein, potassium, and sodium. In the chronic phase, you want, in the chronic failure, like chronic kidney failure, regulate protein intake and then fluid intake to balance fluid losses. And some restriction of sodium and potassium is also needed. Vitamin supplements, more protein will be allowed with dialysis. So if the patient is getting dialysis, it's okay to give more protein. You also want to monitor the patient intake and output, or IV fluids. You want to monitor IV fluid. You don't want to give too much, you don't want to give too less. Then the use of diuretics is a controversial issue as to whether to use it. So it depends on the particular stage. If the patient is actually losing a lot of fluid and a lot of nutrients, why would you give a diuretic? You don't want to do that unless there's fluid buildup. So use of diuretics is a little controversial with acute and chronic. So chronic, they will have accumulation, so that you will give edema. Then aluminum hydroxide is used for elevated phosphate levels, and you encourage bed rest in the acute phase. Good skincare is needed. You want to monitor for signs of infection and antibiotics if there is any needed. Let's talk about renal transplant. I also did talk about renal transplant in my one of the videos when I spoke about renal system diseases or renal system, yes, diseases. I spoke about renal transplant. Please look out for this video on YouTube and watch it. We have the donor selection: cadaver, identical twins, tissue match, and histocompatible, those who die at the cadaver. Pre-op client education, you want to educate the client. So you want to explain the surgical procedure and follow-up care to the client. You want to show client where the donated kidney will be located, whether it's going to be located on the right side or the left side. You want to show them. You give them immunosuppressive drugs. So this is for the donor. They take immunosuppressive drugs. That's prednisone, Imuran, and cyclosporine. So the need for infection is also prevented, gingival disease and cavitis. So we have the post-op vital signs, yes, you will do, vascular access, psychological support for donor and the recipient. And then you monitor for complications such as hemorrhage, shock, rejection. Remember, I spoke about the type of rejections. We have 3 types. We have the hyperacute, acute, and chronic. Days to months, decreased urine output, you monitor, increased BUN, creatinine, rejection symptoms. You want to monitor that. And then you also want to monitor for infection, pulmonary complication, side effects of the immunosuppressive medications and steroid medications. So you want to evaluate to see if normal kidney function has been re-established. And you also want to monitor, you want to evaluate the patient for acute renal failure to be avoided. You want to make sure you help manage the patient on time to avoid acute renal failure. So for the transplant, the donor and the recipient will both take immunosuppressive medication, okay? And you want to monitor for rejection symptoms as well. So on this note, this brings me to the end of physiological integrity, basic care, and comfort. This brings me to the end of it. This is video 7, and that completes the whole chapter or the whole topic for physiological integrity, basic care, and comfort. Watch out for other videos on physiological integrity. I have pharmacological and parenteral therapies. I have reduction of risk potential. I have physiologic adaptation. Other videos are coming. This is still part of my discussion on the test plan. So you want to watch out and get these videos to watch. Okay, so reach out to me if you have any questions, any concerns, anything that you need to address with me. You can reach out to me, send me an email, make a comment. Besides that, there are all these videos on YouTube you need to watch. You just have to learn it and pass this exam. You need to know this stuff. These are from your test plan. Okay, so see you later and have a good day. Bye.